after a few very busy weeks with all of the holidays and things like that. So I can imagine that it has been a bit jam-packed trying to get everything in. So I do appreciate you giving your time up this evening for this panel. And I do want to also thank everybody who is in the Let's Talk Period community for joining this evening as well. So tonight's event, Let's Talk Endometriosis, Pelvic Pain and the Research, that sort of came about as a way to try and discuss some of the things that have been happening in the endo community recently, trying to bring some light as to what the research is showing, where we're sort of heading with endometriosis. And I know the guidelines are also quite a hot topic as well. So trying to discuss those because they've been brought to the forefront of the community's attention recently. So I thought it could be a good idea to hear from some of the researchers within Australia around what they've been working on and where we're seeing funding being allocated, what we're trying to sort of look into further when it comes to endometriosis and treating endometriosis and also managing endometriosis, not just the symptoms, but also the sort of side or comorbidities that can occur with it as well. So mental health and other conditions too. Before starting, I would just like to do an acknowledgement of country. So I would like to acknowledge the Gayabal and the Jarowair peoples. So that's the land on which I am coming from this evening. The Gayabal and Jarowair peoples, I would like to pay respect to the elders past, present and emerging, and I recognise their continued connection and the important work they have done for thousands and thousands of years in nurturing this land. I would also like to pay my respects to any First Nations peoples who are here today, and I acknowledge that this land was never ceded and it always is, always was, always will be our Aboriginal people's land. So without further ado, I'd like to welcome the panelists this evening. So each panelist is going to introduce themselves just briefly and just sort of share about them. So I'll pass to you first, Mike.
Sure, thanks, Isabella. I apologise, I've been quite unwell and still not feeling 100%, and some of the medication I've taken make me a little bit sleepy. So I apologise if I am not as sharp as normal, or it could just be my accent. So I hope you'll understand what I'm saying. So I am a Senior Research Fellow in Reproductive Health at Western Sydney University. Most of my research is on endometriosis, but I also look at menstrual health literacy, specifically around designing interventions to improve menstrual health literacy in young people. I run clinical trials, I do surveys and focus groups. So I guess I've got a reasonably broad range of research. But my main focus at my university job, the one that I usually get funding for, is around complementary medicines. So you will have seen that, you know, some of the studies that have come out, I've been involved with those. And I'm also fortunate enough to be the chair of the Australasian Interdisciplinary Researchers in Endometriosis, and a few other bits and pieces, not that important really. So thank you for having me tonight.
Thank you. I'd also like to welcome Millie. Millie, if you could just share a little bit about you, that would be fantastic.
Thanks, Isabella. So my name's Millie and I am a current third year PhD candidate at the University of South Australia, and I'm part of the Body and Mind group. And so we're focused on persistent pain and how we can better manage persistent pain across a variety of different conditions. So I guess how I fit into the pelvic pain story, I suppose. I was actually diagnosed with endo. I've only just realized this as I've logged in. It was my 10-year diagnosis anniversary actually yesterday. So when I was 14, I was diagnosed. And so, yeah, I have that lived experience of pelvic pain. And I guess I've always just been really passionate and intrigued by it and how we can make management of pelvic pain better. So my project specifically is looking at how we can optimize pain science education for people with pelvic pain. So learning what happens when we have pain, why we have it, how we have it, And I guess those changes we see along the way, so going from acute pain to chronic pain. And when we teach people about pain, we can find better ways to manage it. And so, yeah, I guess that's my little story of how I want to help better influence the pelvic pain community.
Thank you. And I don't know if I should say happy anniversary, because it's not really a happy anniversary, but it always is good to get those answers. But thank you so much for sharing and telling us a little bit about how you fit into this space. I would like to pass on to Antonia now. Thank you.
Oh, hello, everyone. It's Antonina, and I'm a professor of health psychology at Deakin University and registered psychologist. At Deakin, I lead a lab called MIRF, which stands for Mind Body Research in Health. My career has largely been on the brain-gut relations and developing psychotherapies for people with chronic gut conditions. However, several years ago, I think about 12 years ago, I was diagnosed with endometriosis. So naturally, I got interested in it and started developing solutions to improve quality of life, reduce pain, improve improve mental health, but also trying to establish biopsychosocial integrated care in endometriosis, which I've done in some gastroenterology clinics. So I'm sort of trying to apply what I learned in another discipline to treating endometriosis.
Thank you. And I do apologize for mispronouncing your name.
That's all right.
I would like to pass over to George now. So if you can share a bit about you and your work, George.
Thanks, Isabella. Hi, my name's George Collins. Oops, I'm in a chair that just collapsed. I work at the University of Sydney and also Nepean Hospitals as a clinical academic. As a gynecologist, my special interests are in ultrasound diagnosis and non-invasive diagnosis of endometriosis. And I also work in a multidisciplinary team as one of the advanced laparoscopic surgeons performing excisional surgeries. So the work that my team has been focused on over the last 5 to 10 years has been around using ultrasound to help us get an understanding of what the pelvis may look like before we decide to either intervene surgically or consider managing patients non-surgically. I'm the lead investigator for the International Deep Endometriosis Analysis Group. And we just had our pilot data been accepted for publication in one of the big European journals. And I think that the advances in ultrasound, particularly high resolution ultrasound performed by experts, is a way in which we can almost have an overview of the pelvis without necessarily having to put sharp instruments into someone's tummy to get a diagnosis of endometriosis.
Thank you. I think it's very interesting to see where that's going, and hopefully we can have diagnosis without having to have a laparoscopy eventually. So I'm sure we'll dive into that a little bit further on in tonight's chat. I would like to now pass on to Jane, if I may, please.
Hello, everyone, and thanks for having me, Isabella. I'm a reproductive pathologist. I'm based at the University of Otago in Dunedin, so way down in the deep south of Aotearoa, New Zealand. I have a particular interest in the uterus, particularly as it relates to the menstrual cycle, and of course also an interest in things like endometriosis. So as well as the biology side of things, I'm also involved with various studies exploring the psychosocial aspects of the menstrual cycle, endometriosis, and also polycystic ovarian syndrome, questions related to unmet needs or education and information resources, various things like that. I'm really lucky to be able to work with a very large group of amazing colleagues who all have different types of expertise. One of the big projects we're involved with at the moment is trying to establish an Aotearoa-based menstrual health research network. So we're aiming to bring together researchers from all sorts of backgrounds so that hopefully by combining our strengths, we can hopefully improve our chances of making some of the changes that we need for the good of the community.
Definitely. Thank you, Jane. Finally, but not last but not least, I would like to hear from Lisa. If you could share a little bit about you and the work you do.
Thank you, Isabella. So my name is Lisa Van Ekerk. I'm a clinical psychologist. I'm part-time in private practice and then part-time in research at the University of Tasmania. I'm in their Hobart campus. So my interest in research with endo actually flowed on from the work that I do clinically. I work in an interdisciplinary practice and see a lot of women with endo and other forms of persistent health conditions. So the endo research that I do mostly focuses on couples, quality of life, mental health outcomes, and also researching psychological treatments for the consequences of endo.
Which are so important because it's not just one aspect, it affects so many, including our mental health, as I said at the top, so very important. Thank you everybody for sharing a little bit about you. I would just like to remind everybody that we can chat and have questions in the Q&A section, but they won't be answered until the end of the panel because we have had over 90 people register for the event and I've had about 50 questions submitted. So I wish I could answer everybody's questions tonight. I've really tried to sort of group together some similar questions so we could get to as many people as possible. There were some quite personal specifics in some questions around like personal circumstances and things like that. And unfortunately, anything around like medical advice specifically, it's not really that type of event. You really should be trying to seek out personalised medical advice from your healthcare practitioners. So if you're after second opinions and things like that, I really do implore you to go and do that. But we can't answer any personalised questions this evening. So if we don't get to your question, I do apologise. As I said, we've had so many come through, which speaks to the importance of events like this. And yeah, I've tried to sort of get to everyone's question where possible. So I would also like to note, there have just been a few people mention if we could try and make use of inclusive language, making sure that we are using assigned female at birth or being inclusive. So without further ado, I would also like to just mention to our attendees this evening to keep it professional, to keep it polite. If you have a question, ask it nicely and to use kind and polite language. That would be much appreciated. Anything which is rude or abusive or anything like that, it won't be delved into and we won't be discussing that any further. So let's dive into the questions that we have had come through prior to the event. So the first one is all to do with the RANZCOG guidelines, and I know this has been a very hot topic since about the start of March. There's been a lot of commentary around the RANZCOG guidelines. I don't think a lot of people within the endometriosis community knew about them before March this year, and since they've been made aware of them, there's been quite a push to change or update these guidelines. Mike, you were a part of the working group with these guidelines. I'd love if you could sort of share some light around the process of developing the guidelines and around what your thoughts are around the need to change them, and anybody else on the panel this evening as well, you're more than welcome to share your thoughts as well.
Yeah, sure. So I think it's important to say at the outset, obviously it's a very it's been quite a vocal and controversial topic on social media. So I'm obviously speaking for myself, my involvement in the guidelines, not for anybody else. So I was part of the endometriosis expert working group specifically to provide input on complementary, the section on non-surgical and non-pharmacological therapies, but I was involved in the entire process. So a couple of things which probably aren't super clear from the document unless you really dig into it is that this is actually an extension of the NICE guidelines, which were developed for endometriosis. So that has some positives and some negatives. So what we were doing is we were coming from the NICE guidelines, and so we were working within the framework that they'd already created. So the questions have mostly come from the NICE guidelines. We added a couple ourselves, and you'll see in the guideline document, it mentions old questions or existing questions. We searched the literature from 2016 to 2019, I think it was, basically after the last time the NICE guidelines were updated. If we had new questions, we went all the way back and we searched for a long time. The reason that's important is some of the studies that were previously excluded by NICE based on their criteria meant that if they'd already said a study was not included, we couldn't go back and include that study. Not ideal from my point of view all the time, but it was a necessary evil because of the huge amount of work that was involved in creating the guidelines. Obviously, for each question, we had to review the literature. But that's really important to say. So sometimes when you see, when we're talking about the evidence summary and we list the references, some of those are only the papers that have come out since the NICE guideline, but we were using the evidence from the NICE guideline as part of our decision-making process. So with that said, really the idea behind the guidelines was exactly, was really about the diagnosis and treatment. So I think something which is really important to understand is these are really designed as guidance for someone who comes into their GP or their gynecologist with some kind of pelvic pain. So they don't have a diagnosis of endometriosis necessarily. So this is basically from presentation all the way through. So that's why you'll see things like when we talk about suggesting trialing non-steroidal anti-inflammatories, for example. And the reason for that is that around 90% of young people under 25 who menstruate have period pain. And some of that period pain can be very, very severe. So it's not uncommon, even for primary dysmenorrhea, so without endometriosis, to have, you know, pain scores 6, 7, 8, 9 out of 10. And so when someone comes to present to the GP, obviously, you know, part of that is how do we get them through the system to diagnose if they have endometriosis, or if they've got primary dysmenorrhea, how do we manage that for them to reduce the impact? So that's just an example. And the reason I say that is the non-steroidal anti-inflammatory one is that we know that if adolescents especially don't respond to non-steroidal anti-inflammatories, they have a much higher chance of having endometriosis. But you'll see we put a time cap on it. So not too short to see if there's any benefit, but not too long. And that comes out around from, you know, some of the work that we've done with endometriosis patients where they've been told, you know, they've been put on a non-steroidal anti-inflammatory. It hasn't worked and they've just been left on there. So a lot of this was more as well, it's saying you need to not just leave people, you need to move them from that. If it doesn't work, or it's not right, they must go to the next stage. They can't just sit there, you know, being like, oh, well, I've given them some non-steroidal anti-inflammatories, they'll be fine. So I think that's part of the, you know, it's trying to move people through the system so that they're not just stuck somewhere on a treatment that's just not working for them. So that was really the kind of driving force behind the guidelines, is provide some kind of framework for those who might not be endometriosis experts, might not even be gynecologists, might be GPs, might not see a lot of this, to tell them, you know, how should you treat this? What are the steps that you should go through? But the main issue that the guidelines have, like all the other guidelines, and if you read the ESHRE guidelines and other guidelines, you'll find we all say quite similar things. And a big part of that is there's just not enough research out there for many of the things that we're trying to do. And obviously the one that comes up, and it's already in the question and answer section, so we might as well address it head on, is excision versus ablation surgery. So why do we say surgery? Why don't we not specifically say excision surgery? And the answer is, at the moment, the evidence just isn't there to make a strong recommendation for most kinds of endometriosis. We have a few studies, but very few that compare the two, very few that compare them for a long period of time. So a lot of them are very short. They've got really small follow-ups. The one study that we do have from Martin Healy and his team, 2015, followed people for 5 years. And what they found is, for most outcomes, the pain scores were the same between excision and the ablation group, excepting dyspareunia, so pain on intercourse, and those were improved at 5 years, but not actually at a year. So we had to follow them up for a long time to see that change. There was also a slight improvement as well in the medical management. So 24 people, 24% of people, I think, in the ablation, in the excision group were still having medical management, and 35% of people in the ablation group were having medical management. So the excision group was better by about 11%. So about 11% less were having medical management. But the number of repeat surgeries between the excision and the ablation group was the same. So the ablation group hadn't had more repeat surgeries. Now, the problem with this study, it's got shortcomings. Most of it is, a lot of it was mild to moderate endometriosis. So we don't have a lot of studies on deep infiltrating endometriosis. So a big part of it is we need more studies. So it's not that, I think it's really important to say, it's not that people don't care. It's not that we're not interested. We are really, really interested, and we really want to give the best advice, but we're limited in a lot of ways as to how strongly and how concretely we can say that. And a lot of it is based on how the research has been done. And the last thing I'll say is, obviously there is a hierarchy of evidence. I don't know if people have heard of that before, but so we kind of grade evidence in lots of different ways. So at the top, we have clinical guidelines, funnily enough, but we'll leave that to the side. We have meta-analyses and systematic reviews. So these are when you're combining results of previous studies, and we're using kind of some different techniques to understand what the true outcome might be. Because every time we do research, we're basically making an educated guess with the outcome. There's lots of factors that come into it, but basically if we imagine the true outcome is the center here, every time we do research, it's like throwing a dart. We're close, but we're not quite on there. So what we'd expect is over time, you have some positive studies, some negative studies, and then we put them into a meta-analysis, we can see what the true effect is likely to be. So that's where most of the time we take our information from, and most of the time with a meta-analysis, it's fed by randomized controlled trials. So a lack of those makes it more difficult. And also meta-analyses aren't magic. So if there's not great quality research that gets put in, there's not great quality research or great conclusions that we can take out of it. So I guess the thing is that what we really need is better understandings of, what are the outcomes of surgery? What kind of endometriosis is being treated in that surgery? So obviously we expect the outcome's going to be quite different from mild, moderate, deep infiltrating endometriosis. We need to follow people up for long enough to see, what those effects might be, because some of those might not come for quite some time. And obviously another thing we need to follow up is about things like repeat surgery or need for, further medical management. But I think that, as much as I think surgery and excision surgery seems to be really promising, but the idea that it's going to fix everybody and every symptom is, in my opinion, unlikely. And that sucks. I wish it was not true, but I just don't think that many, if any, gynecologists, no matter how skilled, would say that they're able to, remove all of the symptoms, resolve every single issue. So I think it's, we need to be working on that. But, I saw someone asking the question, why am I interested in acupuncture and other things and not surgery? Well, because unfortunately surgery doesn't fix everything for everybody. And also people need choices. Not everyone with mild endometriosis with perhaps milder symptoms, regardless of the stage, maybe they don't want surgery. Maybe they want to try something else. So I think it's, even after surgery, we need to make sure we're looking after people's quality of life. So anyway, sorry, slight tangent. But I think that's, as for whether the guidelines need to be updated, of course they do. All guidelines are designed to be updated, and as new evidence comes out, we really want to update them. On the flip side, it's also a huge amount of work. We went through hundreds of, articles. We had a team, doing all the searches and categorizing them. So it's about balancing, when is something majorly groundbreaking happened, so we need to shift, the guidelines to reflect that. But the last thing I will say is they're just guidelines. there's nothing binding for gynecologists or GPs or anybody to use them. If they think they have a better way of treating, they obviously can do that. No one is, I guess, policing the guidelines. We're not forcing people to use them. They're supposed to be there to be helpful, not harmful.
Thank you. I think that's very true, especially given it that it's the first iteration of the guidelines as well. So prior to this, there was no suggested way for anybody who's presenting with pelvic pain to a health practitioner as to the best sort of way forward to navigate that. So I think it's important to look at that. And then obviously I know it says they're due to be relooked at, I think in 2024. So if sooner, that would be great. But yeah, I think it's like a consistent work in progress from my understanding of trying to balance out new research, when to update them, and research is continually happening. Thank you, Mike. I'd love to pass it to anybody else on the panel who has comments as well.
As someone who performs excisional surgery, and I declare my bias, so and I've been training young ones to do, as in the young doctors that come through our service at the PN Public Hospital to do excisional surgery. But I agree with Mike that it's really important to contextualize the idea of going to theatre and explaining to your patients or those individuals that are going to theatre who are symptomatic, and they agree to surgery, and we believe as a collective that it's going to be a worthwhile decision to move forward. But sometimes surgery is not the answer. And this, I think, is the greatest conundrum about endometriosis, is this idea that you see someone, you get the best possible care, they're a highly motivated team, they are out to get the best outcomes for their patients. And sometimes, despite best efforts, patients are still in pain. And so that's why I think it is really important to have other strategies in place to help support someone through their journey, because it may be that the surgery, if all of their endometriosis results in all of their pain, then they're going to have a great result to the surgery. If 70% of their pain is due to endometriosis, then that patient's going to need some support afterwards. So that's where other strategies come into play. So that's a really important part, I think, of having a team approach, because it's really easy to operate on someone and say, you're fixed, you're cured, see you later. But in reality, that's not always the case. So I think it's important for me, as someone who provides care, to do so in a team environment, so that we've got that ability to support those individuals who don't necessarily get the outcomes that we want.
Thank you. And I think there's a lot to be said for holistic care, and surgery is only one part of that puzzle. And like you said, it would be amazing if we could have surgery be cured. However, obviously there is no cure for endometriosis currently, so surgery is just one option, and then unfortunately it does require that ongoing management approach. I think we might move on to the next question, and this again, I guess, is to do with the guidelines, and then we can discuss other topics relating to research around endo as well. But I would love to know what the research is saying around the use of GnRH agonists such as Zoladex for the management of endometriosis. So currently there's been quite a bit of criticism online with the endometriosis community around the side effects, lack of informed consent, the efficacy of these medications, and then also I know the guidelines are not to be used as this is the only thing that we use, but in the guidelines, they do mention that that Zoladex or a GnRH agonist can be used for 3 months prior to surgery in severe disease. However, the research was limited at the time of publishing. So I would love if we could have a quick discussion around that.
Sure. So with the caveat that Zoladex is not my area of expertise, I'm happy to talk a little bit about the research. So you'll see that that's a consensus recommendation. So what that means is it's not based on particular clinical trials. And you'll see a lot of consensus recommendations, and you'll see what they are is their advice that couldn't really be got from clinical trials. You know, it's not going to be the conclusion of a clinical trial. So I think it's important to show, like number 49, which is also consensus-based, says if initial hormonal treatment for endometriosis is not effective, not tolerated or contraindicated, refer the person to a gynecologist for investigation and treatment options based on the person's preference. So that's also a consensus recommendation. So it's really important to say consensus just means there's not a particular paper or evidence which can help us make that specific decision. We felt it was important that it needed to be said, you know, so that's the kind of thing. So most of the research on Zoladex is about pre-2010. A lot of it is comparing it to another older drug called danazol, which isn't used anymore. And a lot of it is comparing Zoladex plus something versus Zoladex alone. And also Zoladex is not the only gonadotropin releasing hormone agonist. But most of the research, and this is captured in other guidelines like ESHRE, is reasonable, that it can help pain symptoms. But they note that obviously the side effect profile can be really severe for some people. For some people, it's not for everybody. And it's really what they recommend, and the same is what we would assume gynecologists would recommend, is to discuss what the side effects might be, what the benefits might be, and then for a lot of the time it would be trialing the medication to see if it was potentially beneficial. But that's really what the research shows, is that it seems to be effective, and it does have side effects, and that it is better than a placebo. But that's really, you know, that's where most of the research sits. But I'm not a gynecologist, so I can't say how it's used in clinical practice.
Thank you. George, I'm not sure if you could shed some light on this from your perspective.
Yeah, of course, Isabella. Zoladex for me, I see as potentially a circuit breaker for pain. And so in patients that we schedule for excisional surgery, sometimes that operation is not going to be tomorrow, because I work in a public healthcare system, and so the wait list can be between 90 days and 365 days. And even in the private sector, sometimes with COVID interventions, the operation is not going to be tomorrow. So in those women where we're scheduling endometriosis because they've got they're symptomatic and there may be signs of endometriosis on imaging, and the surgery is scheduled, but for some time in the future, I see it as a way to try and arrest pain and give some sort of control back to that person in relation to their ability to function, to go to work, to continue to have some sort of quality of life in the community. And the other time I think about using Zoladex is often we get patients sent to us who have had an operation by somebody else. And that operation may have been only within the last 3 to 6 months. And within the community of gynecological surgeons, you know who performs excisional surgery and you know who potentially ablates. And although I accept Mike's comment that there's not the evidence there, I think if someone has been taught to be an excisional surgery, they've probably got a pretty good understanding of anatomy, and they know how to excise deep endometriosis. So from that perspective, if someone's seen an appropriate surgeon and they come to my team with persistent or recurrent pain, I use Zoladex under those circumstances, assuming that the scan's demonstrating no signs of deep endometriosis, the ultrasound scan, to get an idea if their pain may indeed be still related to the uterus, may be related to the function of the ovary, may be related to the reproductive tract. Because in those individuals where there's no response to Zoladex, that alerts me to the idea that it may be related to the urinary tract or the gut. So they're the two reasons that I use Zoladex, or the two circumstances that I use Zoladex.
Thank you. And I know there's one question that's come up that is sort of relevant for what we're discussing around Zoladex. There's mention around like a lifetime use of around 6 months. So it shouldn't be used for longer periods than that. However, people online are stating that they have been on Zoladex for over 6 months, or they might have been on Zoladex for 12 months. And is there any clinical indication for that? Or what are the repercussions associated with that longer term use?
If someone's going to be using Zoladex for more than 6 months, then there's a detrimental impact potentially on that person's bone density. And so under those circumstances, if there's a response to the Zoladex and if the potential benefit to continue the Zoladex outweighs the risks, and those risks may be related to the side effects or the impact on bone density, then under those circumstances, to get the decisions made, but before continuing beyond 6 months, then that person needs to have a bone density scan to ensure that their bone density hasn't been affected by the fact their ovaries have been switched off for the preceding 6 months. And if they're under those circumstances going to continue Zoladex, then they need to have some form of add-back therapy to protect their bones so they don't end up with bone loss. I think that the idea of long-term Zoladex use beyond 6 or 12 months has, I think, been generated in the situation where there's where particularly in Canada, they historically have had a clinical diagnosis for endometriosis. And because of their socialized healthcare system, it's not possible to operate on someone within the next 2 to 3 months. And so when they believe that someone's got Zoladex based upon their history clinical examination, a significant proportion of women have been put on Zoladex and left on Zoladex for a long period of time. So I don't necessarily agree with that approach. But if there is ongoing benefit from a symptoms perspective, if a patient doesn't want to go to surgery for personal reasons or risk aversion reasons, then to continue Zoladex beyond 6 months needs to be done in a consultative process with a bone scan, knowing that longer term they need that bone protection.
Thank you. I'd just like to ask one more thing and then we can move on for something else. But there's also been instances where people under the age of 18 have been given Zoladex apparently. Obviously, I don't know anyone's personal circumstances. However, I'd love to know if there is any guidelines or recommendations or anything around using this medication for people who are under the age of 18.
I think that the biggest issue in relation to that would be the issue of consent. And so, you know, if you have a young person assigned female at birth that comes to see you that's under the age of 18, then usually that interaction would occur with that person's mother present. And again, from my personal experience, very rare occasions I again have used Zoladex, but it's in a situation where a person may be, you know, not being able to go to school, they're looking at failing their HSC, and we're trying to come up with some way to get them across the line from a point of view of pain management, because also going to theatre in of itself is going to create a situation of time off school. It's going to create a situation where they need to recover. So that's essentially going to feed also into their pain from a recovery perspective. So again, I think there might be rare instances, certainly in my experience, where I've thought about using Zoladex at the age of 18. But I think that the issue of consent is really important under those circumstances.
Thanks, George. I'd now like to flip to you, Millie, and I'd love to hear about the latest findings and what research is currently being done around the management of chronic pelvic pain. I know this is your space.
I feel like it probably need 10 hours to go into absolutely everything. So I guess I'll try my best. But I suppose with my research and research I'm sort of involved with, like with my supervisors and all that, is I guess we're moving into a space where we're treating or considering persistent pelvic pain as a biopsychosocial phenomenon or experience. So unfortunately, like pain, I guess pain in its acute state is really, really helpful for people. You know, it helps us know if we've hurt ourselves or we can potentially hurt ourselves. And unfortunately, when that pain persists over a long period of time, our brain in particular, so pain is an output of the brain and the nervous system. Our nervous system becomes really, really good at overprotecting ourselves, basically. And that can, I guess it starts protecting us from all these different things. So not only biological things like endometriosis, inflammation, hormones, genetics, and all those things, but also our psychological and social factors. So comorbidities like anxiety and depression, trauma, all those kind of things, our social circumstances. So our family and friends, relationships, our work environment, and how that plays into our pain experience. And I think that sort of just highlights how individual pain is. I sort of stop and think about pelvic pain, and it's a bit crazy that pain is this thing that everybody experiences, and if you don't experience it, then there's obviously some issues with that. But pain is this phenomenon that we all experience, yet we can't understand other people's experience of pain. And I think that is just something really nice to acknowledge, that pain is this individual and complex thing that we are slowly learning more and more about. But unfortunately, because it is so complex and involves so many different things, we can't, it's not as simple as, surgery and all those types of things. It's an important step, but I guess acknowledging those other factors as well. So when we talk and discuss about pain, specifically in musculoskeletal pain conditions, so like low back pain or osteoarthritis in the knee, those kind of things, we have extensive knowledge that teaching people actually about how pain works, and that it is not necessarily a very accurate marker of what's going on in our body. When we teach people these things, we see better outcomes in terms of pain and disability. But the problem at the moment is with pain education, it's very much tailored towards those musculoskeletal pain disorders. So we're talking about injuries that might happen at work, picking up a box, or you've gradually got osteoarthritis in the knee. And knees and backs are very different to the pelvis. There's so many vital organs smushed into this small space. And so I think people with pelvic pain, I feel like I can relate to this, but it's not only an issue of the uterus, it's an issue of the bladder and the bowel. And when you add in those social and cultural, religious experiences as well on top of someone's experience of pain, it becomes really complex. And the pelvis is a very complicated area. So our goal is to teach people about pain with considering those psychological and social influences that are quite specific to the pelvic pain experience. So I've just conducted some interviews with 20 people, and they've given me their experience in engaging with pain science education and how that has improved in their pain management. And it's just so humbling, and I feel very fortunate and lucky to actually sit back and listen to these experiences of possibly awful experiences, getting a diagnosis, but then hearing their experiences, learning about pain, which is often self-directed if health professionals don't actually integrate this within their care. And so we're using this to find out what are the really important things that people with pelvic pain want and have found really important for them in their pain management journey. And yeah, it's just been such an eye-opening experience, and it's great to hear these patient voices, because I feel like they're something that very much needs to be amplified within the pelvic health and pelvic pain community. So I guess that's one thing that's going on, and we're sort of extending that in. My supervisor is running a feasibility trial to try and integrate some of these pain science education things and teaching people about how pain works before they go in to have a laparoscopy. So can we better these outcomes for people going into surgery, and can they, I guess, better their management post-surgery as well? So that's another exciting thing that's going on. And I guess outside my lab, learning more about the neurobiology of pelvic pain. So things have come up to do with functional MRIs, so looking at people's brains and seeing what's going on inside of them, and seeing that there's actually these structural changes happening in people's brains that have pelvic pain, to demonstrate that there are these changes happening within the central nervous system. So that's another really interesting aspect. And I was also at the Australian Pain Society conference recently, and we had a professor talking about research into vulvodynia and looking at how the nervous system, and I guess into that histology of that I guess contributes to vulvodynia, all of that sort of stuff. So looking at increased nerve fibers and looking at the role of the nervous system that way. So there's definitely some really interesting things that I guess are extending beyond just looking at the pelvis solely, but looking at it as a whole body experience, which I'm sure some of these people here will touch on as well. But yeah, just treating pelvic pain as a whole body thing, that it's not just focusing on your organs and your tissues. Like, this contributes so much to someone's life and quality of life. And hopefully by teaching people these things, we can better off their experience and help them better manage their pain as well.
Oh, thank you so much. And I think it's so true. Hopefully, through all of this teaching and all of this research that's ongoing, that we can improve the quality of life for people, because it is not just affecting one aspect, as you said, it's so multifaceted. So I think all of this important research, I think the MRI studies sound absolutely incredible, and I can't wait to hear more about that, because yeah, I didn't know that. I would love to ask you, Jane, all about your role, and if you are sort of able to share what's currently known about endometriosis, and are we making any advances towards finding a cure? I know there were quite a few questions that came through about how far away are we from a cure? When will there be a cure? We need a cure. And I know everybody would absolutely love a cure, but I guess it's not that simplistic, is it?
No, it's a huge question. And I think even better than a cure would be a way to prevent endometriosis. But unfortunately, I think we are still a long way from either a cure or prevention, because in part at least we still really don't understand what causes endometriosis. And there are several different theories, really useful theories, but none of them actually explain all the aspects of endometriosis. And perhaps if we've got a little bit of time, Isabella, I might be able to go through the one that you'll most commonly see in the lay literature. They're about retrograde menstruation.
Yeah, definitely.
Would you like me to do that now or hang off a little bit?
We can do it now. Why not?
All righty. Okay. Well, so one thing you may have read about in the literature is retrograde menstruation. And to explain that, we need to take a little step back and think about the uterus, which is lined by a tissue known as the endometrium. And an endometriosis tissue that resembles the endometrium is found outside of the uterus in the pelvic cavity. And that's what we know as these lesions. And it's also the endometrium that changes and remodels and then breaks down and bleeds as part of the menstrual cycle. So the bleeding, of course, is what we experience as menstruation. And most of the blood and the tissue that breaks down exits the body down via the vagina. But some of it can also be pushed backwards through the uterine tubes and into the pelvic cavity. And this is this process known as retrograde menstruation. And this is a really good theory to explain how bits of tissue that look like endometrium get into the pelvis. But the problem with the theory, or at least one of the problems is the theory, is that it's thought that the majority of menstruating individuals will have this retrograde menstruation. So it doesn't explain why then a proportion, just a small proportion of those people will go on and develop endometriosis. It also doesn't explain why some people might get lesions in some pretty unusual places. So it's a useful theory, and there are lots of others, but it doesn't, there are no one theories that will explain the disease. So coming back to the research though, although I don't think we're going to see a cure anytime soon, on the positive side, there is an intensive research effort going on internationally now, looking at ways to improve our understanding of the disease. And just before this, I went and had a look on PubMed, which is one of the databases we search through if we're looking for papers about things like endometriosis. And in 2000, the year 2000, there were 450 papers published about endometriosis. But in 2020, there were over 1,900 publications. And I think that research effort is only going to increase. Researchers worldwide are aiming to improve our understanding of what causes the disease, but also hunting for improved diagnostics and improved therapeutics. And I think the example we've heard about a couple of times, and hopefully we'll hear from George a little bit more about, has been about the improvement in the imaging techniques to diagnose endometriosis. I'm involved in several research studies, and I know there are numerous others worldwide looking with diagnostics as their goal. So we're looking for potential biomarkers in blood samples, and we're also now just starting to explore the possibility that we might be able to find markers in cervical smears as ways that we can obtain tissues that in a non-invasive way. We know that there's genetics involved in endometriosis. It does run in families. And there are some examples of diseases where there's a mutation in a single gene. And if you have that mutation, it causes the disease. Endometriosis is not like that. The genetics is really, really complex and involving multiple different genes throughout our DNA. So the genetics is not going to give us a diagnostic tool, but what all this huge effort that's been put into this work has done is help to identify some of the biological pathways that we should be exploring to try and better understand the disease. We also know that there'll be strong role for environmental factors, and there could be all sorts of different things, potentially diet or stress, early life events, and some of the things that you'll see suggested in the literature. But these are incredibly complex issues to try and tease out, and we are a long, long, long way from pinning down specifics. This community in particular knows that the symptoms can start quite early on, so in our young ones. And so I think it's important that we start now focusing on looking for those risk factors in those age groups, things that could be happening in children, or even when a baby is still in the womb, still in the uterus prior to birth, when risk factors might actually be developing. I think I could go on for ages, but I'll stop. But I think although we are a long way from a cure, I think the positive message to take away from a research point of view is that all the effort that's being put into the increased recognition of the impacts of endometriosis on individuals and on the community is that it's helping us as researchers gain a little more traction as we're trying to gather that funding so we can answer some of these questions.
Thanks, Jane. I know there's quite a few theories, and there's a few people in the comments currently. Some people are saying that retrograde menstruation's been proven incorrect or it's been debunked. And I know there's quite a number of theories around endometriosis. However, we actually don't know the distinct cause of endometriosis as of yet.
No.
All we really know is that it's tissue that's similar to the lining of the uterus, so it's similar to the endometrium, and there's theories of how endometriosis can occur, but we haven't got an understanding definitively of how it occurs as of yet.
No, and noting some of those comments, certainly we know that those lesions do have the capability of producing their own source of estrogen. But again, that doesn't tell us where those lesions have come from in the first place. That obviously contributes to the pathophysiology, the ongoing etiology of the disease, but it doesn't tell us about where they came from in the first place.
Exactly, thank you. I would like to ask Lisa and Antonina about the mental health impacts, and we know just from some of the other people that have spoken tonight that mental health and endo kind of seem to go hand in hand. And I'd love to know what sort of interventions are effective or what has been researched around what we can do to sort of negate those mental health impacts of having a chronic illness such as endometriosis, and what research is currently being done into endo and mental health.
So I'll go first.
You start, yes.
Yes. So for most people with endo, when they're working with a psychologist, they're working on managing the consequences of endometriosis. So whether that is the consequence of distress associated with the diagnostic journey and the length of time that it can take, whether it is, what we would call sort of interpersonal or medical-based trauma, because often that diagnostic pathway, there are multiple visits there that involve, one or more of the primary care givers. So there's often a lot of distress and interpersonal trauma attached to that process. So in terms of therapies, rather than viewing it as a one size fits all, really it's about working out exactly what that person is experiencing, what the process has been like for them. So it may be that you're working on depression or anxiety. It may be that you're directly targeting trauma. So that might be through trauma-focused therapies. It might be through cognitive behaviour therapies, other mind-body therapies, including compassion-focused therapies. So it's not a case of a psychologist will only work in one area. They'll work with the person in terms of what they're presenting. That may also include couple work or family systems work as well.
And I'm happy to add to that, sort of from the scientific point of view, it's quite interesting why sort of endometriosis is associated with relatively high rates of mental health, and there's quite a few reasons. So whenever you work as a psychologist with people with chronic illness of any type, you see more of anxiety and depression, particularly if these conditions are very unpredictable. But here we also have the chronic pain aspect, which in itself is incredibly hard and frustrating to treat and very, very disabling. Sort of something of interest to me personally is this comorbidity with irritable bowel syndrome and all this, constant bloating, and how do we deal with that? But also inflammation. That is there, and having worked with chronic inflammatory conditions such as Crohn's disease, we know that this ongoing inflammatory process is responsible for a lot of depression and anxiety, which actually, when you give an anti-inflammatory drug in something like Crohn's disease, pretty much drops by half at least. So clearly there is a relationship. In terms of how we treat, so the problem that we have, like we in any area to do with endometriosis, is that we borrow from other disciplines because there's very little endometriosis specific evidence. We did a study with a colleague of mine, Dr. Subhadra Evans, a few years ago, where we collected all the studies examining different interventions, so something called a systematic review, and we only really found 2 trials. They were very small and not particularly great. So the conclusion was, look, something like CBT, so cognitive behavior therapy, yoga, mindfulness might potentially be helpful, but we talk about really limited evidence in endometriosis. So what psychologists do, we borrow from general pelvic pain area, and we know that certain solutions such as CBT, for example, or acceptance commitment therapy, a few others, like, for people with IBS, something like gut-directed hypnotherapy might work. But having said that, we are working hard to try to develop evidence specific to endometriosis, to develop CBT programs, yoga programs that are for people with endometriosis. And I know it makes a difference because in gastroenterology, for example, things that were developed for people with Crohn's or colitis or IBS specifically, they make a difference. It's different to be given sort of a general CBT and different to meet with a therapist who actually understands your condition and can come up with individualized program.
Thank you. I think that's really important to note, and trying to take one thing and apply it to everything doesn't always work. And I think that individualized approach, even if it's just that one condition, individualizing it to sort of a common set of things that people with this condition experience is so important. So I can't wait to see all the additional interventions that can hopefully be introduced for people living with endo in the next months and few years as well. Is there anything else that you're wanting to build upon there, Lisa?
I think just one of the other things that I'll add is that one of the difficulties for people with endometriosis accessing mental health care is adequate Medicare funding. So at the moment in Australia, we obviously have better access to mental health. So people can access 5 sessions under an enhanced primary care scheme, but that 5 sessions may include 1 session with a psychologist, it may include 2 sessions with a pelvic floor physiotherapist, 1 with a dietitian, and you have 5 for that calendar year. The alternative pathway is under a mental health care plan referral, and some GPs won't refer people under that pathway because they say, well, actually, this is a physical condition, so you can only access the enhanced primary care plan. So a lot of the work that we do is also, helping people to go back to their GP and say, look, I am eligible for a mental health care plan that now currently gets people up to 20 Medicare rebatable sessions. But, one area we do need to lobby is for more affordable bulk billed Medicare funded treatment for people with endometriosis.
Thank you. I couldn't agree more. And I think really lobbying to have that mental health care plan for yourself, as opposed to using those 5 sessions across the board, is so important, because you can use those 5 sessions for something else. As we know, living with a chronic illness is very expensive, and so being able to access as much help as possible is so important. I'd like to toss to you, George, and I know you've been speaking here and there throughout the evening about the role of ultrasound, and I know recently there was funding announced or promised, should the current government be re-elected, into the further research into ultrasound and the potential use of that diagnosing endometriosis as opposed to laparoscopy. I'd love to know if you could sort of share what advances are being made there and what have we seen come out of all of this, and where are we going in respect to diagnosis?
So one of the questions I get asked a lot is, or I'm told when a patient comes to see us for a deep endometriosis ultrasound scan is, well, I've had an ultrasound scan before. I don't really understand why my doctor's sending me to have a scan. I've already had one done. And so not all ultrasounds are the same. And so most units, including my units at Nepean Public Hospital, and most general radiology units, when asked to perform a pelvic ultrasound scan, will do a basic pelvic ultrasound scan. So this will be an internal transvaginal scan where the sonographer will look at the uterus and ovaries. And so if a patient's got endometriosis cyst or an endometrioma, then that can be seen. If there's signs of adenomyosis in the uterus, likewise, this can be seen. But we all know from experience that having a normal pelvic ultrasound scan, when you subsequently take someone to theatre, there can be a real mismatch between the normal scan and the extent of endometriosis when someone is actually under the anaesthetic at the time of their laparoscopic surgery. So what we've been trying to do, and not just my unit, but many units around the world, individually, but also as a collective under the IDEA group, is we've been trying to bridge that gap. We've been trying to get as much additional information out of an ultrasound scan before surgery or before treatment, so that we get to know whether someone potentially has low stage or high stage disease. And so deep endometriosis ultrasound scan, when performed by somebody who's trained to do this, and I clearly accept that there's an issue in relation to accessing this sort of imaging, although there are some units that do provide this in the Medicare system, in the public healthcare system, and it should be every person's right to have access to expert imaging for endometriosis. But when we do an ultrasound, a deep endometriosis ultrasound scan, it enables us to map the location and the extent of the disease. And in those patients that have got high stage disease, it enables us to, particularly if they're going on to have surgery, to plan the surgery with a multidisciplinary team. And we know that you get the best outcome surgically if patients have the right team around the surgical table at the first surgery. So if a patient's got bowel disease, then we interface with the colorectal team pre-surgically. If there's bladder disease, we interface with the urology team pre-surgically. If there's signs of diaphragmatic disease, we interface with the upper GI team pre-surgically. And so ultrasound can help tremendously with mapping out deep endometriosis and locations for deep endometriosis, particularly in the ligaments that support the uterus, the uterosacral ligaments, the rectum, the vagina, the space between the vagina and the bowel itself, the space between the cervix. and the rectum itself. So it's really important to not be so, what's the word, dismissive that the technology is available and not going to make a difference to your management plan, because I think they really will. And so we do know that if these surgeries are planned, high-stage surgery, high-stage disease is planned by the right team, then they're more likely not just to get the best outcomes. The consent is an appropriate consent pre-surgically, so the patient fully understands the risks associated with that multidisciplinary team going to perform excisional surgery. And also, if you know what you're going to be in for before you go to theatre, you're more likely to mitigate the risks associated with surgery. And doing bowel surgery is associated with potential rectal leak, is associated with potential fistulas between vagina and rectum. So having the right team is critical to that. Now, I fully accept that superficial endometriosis, for the most part, cannot be seen on ultrasound. But even having a normal deep endometriosis ultrasound scan is really a powerful tool, because it helps the patient understand, and also the potential surgeon, that there's not going to be necessarily high-stage disease. They're not going to need the colorectal team. They won't need the urology team. It's going to be a relatively straightforward excisional procedure, and the risks are going to be much lower than those with high-stage disease. So whether the deep endometriosis scan is normal or whether it shows the presence of other organs being involved, I think it's a really important tool that we should be considering when it comes to mapping out, but also planning management strategies.
Thank you. And I think having that information prior to going into surgery, whether it's seen on scan or not, really does inform who, like you said, who will be needed in that surgery, and it can give some information prior to going in, even though I know there's people who do not have deep endometriosis, so it might not necessarily be seen as helpful for them, but it could definitely provide some sort of answers without having that full answer yet before that surgery. Yes, George.
One final comment. It's so important to understand that none of us do, and none of us should ever manage an ultrasound scan report. You manage the patient. You manage the patients and the severity of their symptoms. You manage the patient in the way in which they impact on that person's quality of life. You manage the patient in the way in which, as we've talked about tonight, those symptoms impact on their mental health and their well-being moving forward. So the ultrasound is just one part of the puzzle. The decision to manage those patients is based upon what the patient wants, what the risks are of the intervention, and how much the disease is impacting on their quality of life and potential fertility.
Yeah, thank you. There have been just some comments come through around that endometriosis can only be diagnosed via histology. And yes, that's correct. Currently, the tissue needs to be sent away. However, through the use of ultrasound, please correct me if I'm wrong, Georgia, you can discuss this, I'm sure. It can be characteristically seen, and it can be not confirmed that, yes, you have endometriosis, but it can be identified that it is highly likely that they might be suffering from endometriosis based off that ultrasound.
Yeah, I think the changes in many aspects of gynecological management, and even in the cancer field, when we look at ovarian cancer and using ultrasound to morphologically assess the likelihood of benignity versus malignancy. I think that ability to using our brain and having the ability to pattern recognize the different changes to somebody's pelvis when there are abnormalities present, I think does enable us to, as you say, to characterize the pelvis and the likelihood of pathology, and also the likelihood of high-stage disease, which in turn I think enables us to predict the level of complexity of laparoscopic surgery. Lovely,
thank you. I'd like to move along to funding now, because I know we're already kind of going over time. This is one of our final questions, and then I will try and open up the floor for questions. I know there's already quite a number in the chat already. So again, we might not get to all of those this evening because there's already 17 and we haven't finished this evening. But I would like to talk about funding, and I know this is one of the biggest blocks to research. So I'd love to hear from all of you around where and how we should be making investments towards our approach for endo. There's been a lot of criticism online around why aren't we funding excision surgeons? Why aren't we funding endometriosis surgeons? Why is there funding into alternative therapies? And as if the people who are receiving funding are in charge of where the funding gets put towards. So I'd love if we could potentially share some light around how these decisions get made, who's involved, who decides where the money goes, and what's sort of been going on, if we could sort of de-muddy the waters a little bit.
I might have a crack at this if that's okay. So probably just some context first, because many people might not understand about an academic's job and what we do as researchers, and it can be a bit surprising. So when you get hired as an academic, you have a salary. So the university pays me. What they don't do is they don't give me any money to do my research, generally. So if you can imagine, it's a bit like being hired to be a used car salesman, and you turn up to sell a car and the dealership is like, yes, we need you to sell a car. We don't actually have a car. So what we're going to need you to do is get a car or borrow a car from someone else and then sell it. So we don't actually get funding much at all as part of our day-to-day jobs. So everything that we need to do either comes as unfunded. So this is where we're doing it in our own time, or it's being funded by someone else. So I would say about half the research that I personally do, if not more, is unfunded. So that means it's a project that me and some other academics are working on. We're doing it in our own time. So our EndoCost study, for example, was done completely without funding. So we did all of that, just funded, just our own time. So it takes a long time sometimes because you're working on nights and weekends, but it's usually things that we're really, really passionate about. Other sources of funding are either internal grants from our university or external grants, and these fall into a couple of different categories. So internal grants tend to be quite small. So for example, the acupuncture study that I did that someone was asking about, that was a $17,000 internal grant that I did. And so basically I did all of the work. We didn't really have any money to pay people. So you can get research done on these shoestring budgets. It's pretty unpleasant, but we can make it work, especially if it's something that we're really interested in. External funding comes from usually one of two major sources, and other people can jump in because they might have different experiences, but it tends to be either competitive funding from a government type body or a large organization. So these are things like the National Health and Medical Research Council, or NHMRC grants. These are MRFF grants, the Medical Research Futures Funds, ARC, Australian Research Council. So that's competitive research. Those grants take a lot of time. They're assessed by panels of experts, and then they're usually ranked. And if you're incredibly lucky, and mostly lucky, you might get one of these NHMRC grants. So for example, one that I've put in for the success rate, I think is 9% or something like that. MRFF grants, similar. ARC grants are similar. The other funding can come from industry or companies. So for example, if you've got, and this is obviously what happens in pharmaceutical research, you might have a company that makes drug X, and we think drug X is going to be amazing for endometriosis. It's going to reduce pain. So they will ask academics who have expertise in the area to design a clinical trial, for example. We get their funding and we work independent of them to look at how this drug might work. So those are kind of main areas of funding. So a lot of the time, what gets funded is firstly, what are people put in, for? So you obviously can't get funded unless you apply. So if people are asking about, well, why are surgery clinical trials not being funded? And the answer is, they're either not being funded because the quality of the project that's going in isn't meeting whatever standards the particular funding body has. And that's not to say these are bad projects, but it's very hard to get funded, or these trials are not being put in. So it's really hard to say. We obviously don't know about all the ones which aren't successful, but it's finding a team that has expertise in that particular area and then, you know, they'll develop the project, they'll put it in for funding, and they'll hope they're successful. So that's generally how the funding process works. And obviously each of us, as you can tell tonight, is completely, our expertise is quite different. So, you know, I wouldn't necessarily, without someone like George or several surgical experts, I wouldn't be branching out and running a clinical trial on surgery, for example. But I would feel quite comfortable running one on medicinal cannabis or something else, which is really within my area of expertise. So I think that that's kind of, you know, how funding normally works. And I see someone says they want funding for training excision surgeons. I think that's a very different conversation, and that's not necessarily through the same pathways. You know, so obviously the NHMRC or ARC are not going to fund training for something. You know, they fund research projects. So I think that's where it gets really confusing, is that where does the money come from? Well, it often comes from the government, but how it gets distributed is via these different pathways. You know, so if you want funding for training excision surgeons, probably, and George would have a much better idea than I would, but that would be via something like AGIS, you know, and so they would need to somehow put in for some funding to do that. And I think also there's obviously a lot of other assumptions, you know, that go along with that, that there's obviously a whole bunch of, and I don't know, you know, how many people in AGIS are waiting to be trained and how long the delay is and things like that. But I think that, you know, research funding and other funding, although it seems like it comes from one big pool, it's really, really different. And so I think that's a really big, you know, part of the issue, is that, you know, different funding and, you know, what do people want to fund? So, you know, for surgical trials, I would say, you know, if surgeons are wanting to say that their particular surgery is good, then they would be the right people to design a trial and put it in for funding, you know. So I think it's, you know, there's different areas of expertise, and, you know, we tend to want to work within our areas. So I hope that explains a little bit more about the funding process. And obviously if other people have got, you know, different experiences, you know, please feel free.
Yeah, I'd love to hear if anyone else has any thoughts on that.
I might just quite like to add, just in support of what Mike's saying, the other thing with the research grants we put in is that we are putting grants up that are competing with all sorts of different medical and health and biological issues. So we're not putting funding in that is just for endometriosis in the vast majority of cases. We are putting in grants and then being compared with others that are being done on cancer, on every other possible condition that you can imagine. So it's much harder then when they think that the granting panels are ranking these in terms of which gets funded.
Sorry, Jane, if I can just add to that. Also, it's probably important to note that some funding is what's called targeted funding. So it comes out for a particular condition. It's probably no surprise to anyone on the webinar that we get a very small slice of the pie. You know, so my friends who work in dementia research, for example, I can't count the number of different funding grant rounds and opportunities they have compared to people who do any kind of reproductive health, but especially endometriosis, pelvic pain, period pain. You know, when we compare dementia, diabetes, they're just, you know, they're getting hundreds of millions of dollars of funding opportunities each year. And, you know, I think in total, endometriosis in Australia has maybe had 28 million over the last few years. And to give some idea, that's the economic burden of a single day of endometriosis for the Australian government. So, you know, we could use a bit more.
Yeah, definitely. Comments coming through about the 58 million for the government, that's actually not promised. It's not delivered yet because that's an election promise. So that will only occur if the government that's currently in gets re-elected. And if the other government comes in, they need to have a counter proposal as to how they would fund that. So a lot of the discussions around this $58 million are being allocated to and from and for. It's all just conversations currently because it's not actually set in stone. I'm not sure if anyone who's on the panel tonight could actually discuss as to how it's decided if this was to occur, how it was decided what amounts of funding were allocated to what area. I'm not sure if anybody's able to shed light on that at all. I know that's potentially more of a government decision. I'm not 100% certain.
I'll make a snide comment. I think something like $26 million has gone towards MRI funding, and I think that there's been a significant amount of lobbying by different groups, particularly the College of Radiologists. So I think it's a great initiative to have people to become experts at imaging the pelvis using MRI. And I think that there's strong data to support this as a really good non-invasive diagnostic tool. But I think, in answer to your question, where that money goes, and it's a big if the Liberal Party was re-elected, I think some will definitely go back into the NHMRC grant pool, and then obviously that'll be competitive grant applications that we all have access to. But there is some money that's already been set aside for different groups who I think have lobbied very strongly and very successfully with the Health Minister.
I would just like to say the amount of information that I have on those grants is the press release. That's it. And I don't know anybody who's really got any more information than that. I have to say, it was a complete surprise to me. I think we found out 24 hours beforehand that they were going to announce $58 million. I have no idea how they decided what they were going to fund. It's still really unclear what they are funding from my point of view, because that set of bullet points it's just a set of bullet points. It could be great. Some of it, the multidisciplinary clinics could be fantastic. But it's so hard to know because that's it. We don't have any more details about what they're actually going to do.
Exactly, and it's not even confirmed yet. So I think it's something to be potentially excited about, but we don't know anything further. So until we know more, I guess election day is 21 May. So it all depends on who's voted in. George?
Just a quick comment. I know there has been some questions in relation to increasing the number of excisional surgeons, and as an AGES supervisor, and I'm on the board for AGES, so the Australasian Gynae Endoscopy and Surgery Society, we're forever trying to expand the number of training units that we have within Australia and New Zealand. There's currently around 25 training units. Each fellowship lasts for 2 years, and most of the individuals that do those training fellowships do so over and above their 6 years of basic training to be an obstetrician gynecologist. So they take the 2 years out. It's expensive for the trainees to undergo the training, and it's also expensive for the trainers to train the trainees. So I think that money going back into training surgeons, I think, would be a great initiative. I think this is happening. I think also, for the most part, in the capital cities around Australia. My understanding, when I think of the different capital cities and who's working in those cities in endometriosis surgery, I think most people performing surgery are excisional surgeons. I think as you move to more regional centres, then there's probably more ablative surgeons than excisional surgeons. And there's no doubt that there is an ongoing effort by AGES to expand the number of AGES-trained laparoscopic surgeons. This was started in 2012. And it is growing, but it's a very slow process.
Thank you. And yeah, I can only imagine, and I don't even attempt to try and understand all the complexities. And I think it's really easy to try and simplify everything when we're not involved in these decisions and we don't know about all the behind the scenes things that occur as well. I know that we're already at 8:30 practically, so we might do 10 minutes of questions if everybody is okay with that, and then we might close for the evening because I know we are over time. One question that came up was about, with regards to research and clinical guidelines, is there a consensus around the best first-line treatment for someone who's presenting with suspected endometriosis? So they've given an example. So contraceptives versus diagnostic surgery versus as a first line of treatment. So is there a consensus of like the best first line treatment for endo or suspected endo?
I don't think there's necessarily a consensus. And as Mike said, the guidelines are a potential roadmap for clinicians to use as a resource. I think probably what's more important than that first step is that whether it's the patient's general practitioner or their referral to the gynecologist, I think the most important aspect of their care is that their symptoms are taken seriously. And I think that acknowledgement of their symptoms and understanding that certain symptoms correlate potentially with the presence of endometriosis, the lack of normalization of symptoms in the context of someone's menstrual life by medical practitioners is, I think, a big contributor to this as a problem. I suppose the reduction of being paternalistic in the way in which we manage patients and try to maintain the autonomy of the patients in the decision-making process. But I would say that the most important aspect is taking someone's symptoms seriously.
Definitely. I think there's a lot to be said for that. Another question that's come through is, and I think maybe Millie, you might be able to answer this. I'm not sure if you know of any research around the links or correlations between vulvodynia and endometriosis, and if there's any additional research around sciatic endometriosis at all.
I'm not too sure about sciatica endometriosis, but with vulvodynia, I'm not sure on the exact numbers, but I guess when we look at people with pelvic pain and people with endometriosis, people often present with multiple pelvic pain conditions. So things like vulvodynia, interstitial cystitis or painful bladder syndromes, issues with their gut and their bowels, IBS, those sorts of things can all manifest alongside endometriosis. And that's sort of thought to be this process that evolves, if endometriosis might not be diagnosed early enough. So we've got endo and inflammation going on in the pelvis. And then that sort of leads to our nervous system becoming a bit more sensitive and overprotective of these things. So that's where we see changes, not in only the peripheral nerves that are innervating these organs, but also the central nervous system as well. So like our brain and our spinal cord, where these pain processes are occurring. So I guess if there's something like endo that could be left there and undiagnosed for many years, our central nervous system becomes oversensitive and really overprotective. And I guess the unique thing about the pelvis is that it's innervated by these nerves, but lots of these organs are innervated by these nerves branching from the same spot from the spinal cord of where all these pain processes are occurring. So, and they think it's called cross-organ sensitization. So these nerves that are innervating multiple organs become really sensitive, and then we experience these different pain conditions at multiple sites relating to the pelvis. So that's where it's really quite a pivotal point, is to get that early diagnosis. If you decide to have surgery, and surgery is a viable option for you to get that done, but then also following up on that pain management using other different strategies. So whether that's things like pelvic floor physio to address pelvic floor muscle and those sorts of things, that can be really helpful. Psychological interventions as well, because not only does the psychological component manifest because of the condition, these can also feed back into our experience of pain. So things like worry and fear, which are totally valid experiences to have when having pelvic pain, these things can also contribute to that overprotective response of going, oh, well, she thinks so, they think I'm really worried about this thing. There must be something wrong. Let's go into this overprotective mode and give this person more pain. So in terms of, I think it's just really the different pain conditions that can happen at the one time is quite a unique thing to happen in the pelvis, and possibly that cross-organ sensitization is contributing to that as well.
Thank you. Yeah, I think that could definitely speak to a lot of that for sure. I would love to know, Lisa and Antonina, if there's anything that you have found in clinic or in research about the role of pain and how that sort of translates, and if there's anything, like I know we've sort of touched on that, but it's just there's some things about there's anything to do with, I know we've spoken about with Millie about the MRI changing the brain. I've just had an Instagram message come through from someone who's listening to the panel this evening about the role of the MRI and the role that pain can have on our psychological impacts and our psychological functioning, and how that can translate into everyday and practical strategies that we could use in our everyday if we don't have the ability to see a psychologist.
Yeah, so certainly, when pain is repeated, as Millie's already said, it can change your mood. Those changes in mood can spotlight the pain, meaning that, we feel far more. So it's not that, you are imagining the pain. It's not that, one of the words that people often will be told, and it's a word that, we work really hard to help them remove, is that it's not that you're catastrophizing at all. It is the fact that the more pain you have, the more fatigued you become, your mood drops, and it becomes a very vicious cycle. So there are certainly lots of available resources. So certainly free mindfulness apps. Beyond Blue have a lot of mood gym activities that you can do. So there are certainly access to resources. There's also, and Antonina can probably talk a little bit more about this than at the moment, there's the Happy trial running, which is actually a clinical trial looking at CBT and yoga, the endo that people can enroll in. Antonina, do you want to mention that at all?
Yeah, so we, as I said before, while there's some promise in certain treatments, we don't have this evidence of programs designed specifically for people with endometriosis. So we designed the Happy study. So it's the Happy with I, not Y at the end, the Happy study. And in this study, we compare cognitive behavioral therapy program, which was designed for people with endometriosis, and Lisa has also been consulted on it as an expert in psychology of pain, but also many other people. It's a similar protocol for yoga that was designed for people with endometriosis, and we also have a third arm, which is quite comprehensive education around it, which is our control group. And if anyone is interested, the contact for us is thehappystudy@deakin.edu.au. Obviously, it's a randomized control trial, so I can't guarantee you will get yoga or you will get CBT. You will get one of the three, but we also offer the effective treatment afterwards. So if you end up in a control group, you can still have access after we finish the main study to other avenues. So yeah, we try to find solutions that will be helpful to more people with endometriosis. Hopefully the next step will be there will be more self-directed programs, because at the moment, we have a group of psychologists running the cognitive behavioral therapy and a group of yoga teachers who are trained in helping people with endometriosis. So this is quite a valuable but rare resource, and hopefully we could translate it into something that is in the form of podcasts, something that people can do at home when they have no access to a yoga therapist trained in endometriosis, because largely you need not only a yoga therapist, but somebody who understands physiotherapy here. It's a rare specialty.
The other suggestion that I could also make is that there was a platform recently launched called Endozone, and that actually has a number of pages that are devoted to mental health care, physical health care, that has subsequent links to other free resources. So that's Endozone is where the viewer may also find other resources available.
Thank you. I really appreciate that input and that study. If you have registered for tonight, I will send out a link to everybody tomorrow with some of the things that were mentioned this evening, so you can access that. So I'll put the email for the Happy study as well. And then there's also another research opportunity that I'll mention at the end that I'll also send through as well. We probably have time for one more question. There is one around the use of the oral contraceptive pill that is given to patients when they are a bit younger, so they're teens, they might come into their GP and are given the pill because it might mask symptoms, and it's not until disease progresses further that it's explored for endometriosis. Why is that still sort of occurring, and why is that still happening? And there's commentary in the questions around the guidelines supporting this. I know that the guidelines, as we've said a number of times, aren't concrete and they're not needing to be adhered to, but why is there still instances of general practitioners using the oral contraceptive pill as like a first line defense until the disease progresses so badly?
I mean, I think that if one's going to use the combined oral contraceptive pill, I think that it can potentially improve someone's symptoms. I agree, it doesn't change the status of a person's pelvis. The assumption that I think is being made, though, in some of the comments is that someone who goes to see their GP or see their gynecologist wants to have an operation. And not everybody that I meet wants to have surgery because of their personal preferences, their fear of general anesthetics or otherwise. And another thing that I'll raise tonight, and again, I'm sure this will be quite controversial, do we really know the natural history of endometriosis as a disease? No, we don't. We do not know the natural history of this disease. Not every patient that I see has progressive endometriosis. Is superficial disease the same as deep endometriosis? I don't think we know the answer to that either. So the idea that someone that presents with symptoms in their teenage years, and then that person, if left alone, is destined because of their superficial disease to go on to end up with stage 4 rectal disease with rectouterine adhesions, I don't think that the data is there to support that indeed is the case. And so there is very little data when it comes to expectant management of individuals with underlying endometriosis. There's very little data in relation to follow-up of women after having had combined colorectal gynae procedures to look at the rates of recurrence and if that recurrence indeed is as progressive as one would expect. And no one really understands the timeline. Most of the patients I see with high stage disease, it's the first time I've met them. So there's no way I can quantify with those patients how long they've had the disease for. Now, when you speak to someone, patient symptoms go back many, many years. So I accept that there's a significant chance that someone may have had the disease for a long time, but the assumption that all disease is progressive and that superficial disease becomes deep endometriosis, I think is an assumption, and the science is not there to back that up.
Yeah, thank you. And I think, again, the oral contraceptive pill, and someone else has just mentioned this as well, it has its place in the management of endometriosis. And as we know, hormonal therapies are one treatment option for managing endometriosis, as so many other treatment options are. I've just put a message in the chat to everybody who's in attendance tonight. I'm really sorry if we haven't gotten to ask your question. As I said, we started off with like many questions to begin with before this panel even started this evening, and I had to try and synthesize those questions in addition to all of the other questions that have been asked this evening. So I do apologize if we didn't get to touch on yours. If it was a personalized question to your own situation, unfortunately, we can't give advice around that. And as I said at the start, I really would suggest getting a second opinion and talking with your personal healthcare provider. To close, I would just like to thank everybody for attending this evening. I hope that you have gotten something out of this and that you've learnt something, and that you have been able to sort of understand a little bit about different aspects to do with endometriosis, whether that be funding or research that's occurring as well, because there's been things that I wasn't aware of that I've learnt this evening. I'd also like to thank all of the panelists this evening for giving up their time. As Mike said, this is an unfunded event, and this is something that they're doing out of their own spare time on a Tuesday evening.